Now I know how like difficult ECG as a topic can be, and so I'm gonna try and basically simplify almost everything regarding ECGs and cover up the most basic pathologies that Dr. Simon went over in his lectures. All right, so we start off with ECGs. Now, basically, what exactly are ECGs? So you know how you have electrical activities happening inside your heart, just like I'm gonna change my pen size actually. Yeah. So you have multiple electrical impulses just being generated within your heart, and then all of these electrical impulses are basically going to be depicted on a graph that's called as ECG. Okay, so ECG basically helps you to visualize the electrical activity of the heart. So if there's anything wrong within the conduction system, so if your electrical impulses are not able to travel from the SA node to the AV node, or if your AV node isn't able to conduct electrical impulses, all of that will be shown up on the ECG because it helps you to visualize the electrical activity of the heart, all right? Now, like I said, there's multiple electrical impulses being generated and your atria and ventricles are depolarizing. So summation vector of all the, I don't know why I wrote eccentrical here, I meant electrical. But yeah, summation vector of all the electrical activity happening within the heart is in this direction. So like going back to our basic physics, you remember how we had vectors, right? And so there was like this vector here, and then there was a vector here, and then if you would sum up the two vectors, you would have a resultant vector, which would look somewhat like this. And this is similar to what we follow in physics as well. So, all these electrical activities happening within the heart have a sum, and that is going to be in this direction. Okay, and the reason why this summation vector is important is we're going to come to it in a bit. Now, so this summation vector, this is a wave of depolarization, right? And if this vector moves towards a positive electrode, it's going to show as a positive or an upward deflection. If this same vector is going away from the positive electrode, it's going to show a downward or a negative deflection. Now, this is a wave of depolarization, and by that I mean this is a wave where your cells are basically going to be in an active state of contraction. So this is a wave of depolarization, and this rule applies to a wave or a vector of depolarization. It's not the same for a vector of repolarization. And repolarization is when the electrical activity basically is leaving the cell, and the cell is now in a refractory state where it's not going to contract anymore. So the wave of repolarization, if it goes towards a positive electrode, it's going to be the opposite of this one. So it's going to have a negative or a downward deflection. If your wave of repolarization is going away from the positive electrode, then it's going to have an upward or a positive deflection. So repolarization and depolarization, these waves are going to have different or opposing effects on the ECG. Okay, so once again, to summarize, if you have a wave of depolarization going towards the positive electrode, positive deflection, away from the positive electrode, negative deflection. For repolarization, if you have a wave of repolarization going towards the positive electrode, you're going to see a downward or negative deflection. And if it's going away from the positive electrode, you're going to see an upward or a positive deflection, okay? Now, this is your normal 12 lead ECG. And as you can see, you have lead 1, 2, 3, your AVR, AVL, AVF, the augmented leads, and then the precordial leads from V1 to V6. Now, when I said this is a summation vector of all the electrical activity happening in your heart, by that I mean is that each of these LEDs are going to depict this particular vector. Now, if they're depicting the same particular vector that is shown here, why are the electrical activities in each of these LEDs different? So like, as you can see, LED 1 has a different electrical activity compared to, let's say, LED AVR, right? Similarly, if you see V1, the electrical activity in V1 is different from the electrical activity in AVF. Now, the reason why that happens is because these LEDs are placed on different positions in your body. So basically for LED 1, 2, and 3, they're placed, so LED 1 is particularly placed in the positive electrode is placed on your left arm, okay? Same with AVL, the positive electrode is placed on your left arm. With AVF, your positive electrode is placed on your left leg. 2, your positive electrode is also placed on your left leg, and 3, your positive electrode is placed on your left leg. With AVR, the positive electrode is placed on your right arm, and the precordial leads are placed as follows, okay? So basically what you want to do is you want to memorize these positions, or you just want to know where exactly the positive electrodes are placed for at least each electrode, right? So you might get questions which are going to ask you, where is the positive electrode for AVL placed? And the answer would be left arm. So you want to memorize where exactly the positive electrodes for each of the electrodes are, where exactly the positive electrodes for each of the leads placed, all right? And one more thing, if I'm going too fast, just please let me know, and I'll slow down for you a bit, okay? Now, like I said, each of these LEDs are going to visualize the same summation vector, but from different point of views, which is why when you see on an ECG, you're going to see that you're going to have different electrical activities. All right, so as you can see for 2,3 AVF, for LEDs 1, AVL, V5, and V6, because these are like the most lateral LEDs, and because this vector is going directly towards their positive electrodes, you're going to see that V5, V6, 1, AVL, 2, 3, AVF, all of these lateral electrodes are going to have a very strong positive deflection, okay? And in AVR in particular, you're going to see that there's going to be a negative deflection, okay? Like here, for example, this is a normal ECG, right? Let me just raise this. So here, AVR is always going to be negative, and the reason why AVR is always going to be negative is because this vector is always going to go away from it, okay? Similarly, as you can see, your lateral leads 1, AVF, V5, V6, they have very strong positive deflections, including V4. Okay, 2, 3, and AVF are also going to have positive deflections because this vector actually travels directly towards their positive electrodes, okay? And as you can see, V1 and V2 don't really have that strong positive deflections because they're placed more anteriorly, and because they're placed more anteriorly, the vector does not directly face their positive electrodes, okay? Is that understood? I can't really see the chat, so if there's something that you guys cannot understand, please speak up, okay? Now coming to how you form the classic PQRS and T waves. Now, P wave depicts atrial depolarization, and that is when the atria depolarizes, it generates this vector of electrical activity that shows up as this P wave that is a positive deflection. Now, the reason it's positive is because you have the positive electrodes of, let's say, 2, 3, AVF, okay? You have all these positive electrodes, and if you can see that the summation vector is traveling directly towards them, so your P wave is going to be a positive or an upward deflection. The QRS complex signifies ventricular depolarization. Now, the QRS complex has certain parts to it that I will go into detail. So the way the ventricles depolarize is first the intraventricular septum depolarizes. And the septal depolarization happens from left to right. And as you can see, this vector clearly does not face any of these positive electrodes, like particularly for lead 2, 3, AVF, any of the lateral electrodes that you can think of, the vector directly goes away from it. And because it goes away from it, the initial wave that is usually formed is a negative deflection or a downward deflection, okay? Then the next part of your ventricular depolarization happens when the vector goes downwards, or when the electrical activity goes downwards. So the vector goes this way and now is pointing towards these positive electrodes, and when that happens, you get a strong upward deflection. Now, again, your electrical activity is going to move upwards to depolarize the entire ventricle. And obviously now it's moving away from these positive electrodes, and it's moving away from the positive electrodes, it's going to create a downward deflection, as you can see here, and this is called as the S wave. So this is why you have a Q, which is a downward deflection because of the septal depolarization, the R because of the electrical activity traveling downwards, and the S would be because of the electrical activity traveling upwards. So that basically sums up why you get this particular form during ventricular depolarization. And then T wave is when the ventricular repolarization happens. The atrial repolarization is actually hidden within the QRS complex. So that's why you're only able to visualize the ventricular repolarization. And what did I say for repolarization in particular? If a wave of repolarization, if a wave of repolarization is going towards a positive electrode, it is going to have a negative or a downward deflection. If a wave of repolarization is going away from a positive electrode, it's going to have a positive or an upward deflection. And as you can see, the ventricles repolarize in this manner. So they're going away from the positive electrodes, and that's why there's going to be a positive deflection, which is signified by this T wave. Okay, so this is just an extra slide. Delete it. Right, so now in terms of the PQRS and T on the 6 precordial leads, as you can see, this is a summation vector, and the summation vector points directly positive to leads V6, V5, V4, and a bit of V3, but then you can see that the anterior leads, in particular V1 and V2, the summation vector is quite far away from them, so that's why you don't get a strong positive deflections in these. But as you move upwards towards V6, the positive deflection continues to rise. Okay, and the reason why the positive deflection continues to rise is because obviously these positive electrodes are facing facing a lot more towards our summation vector. Okay, if that makes sense. So from V1 to V6, you're going to see that there's going to be a rise in the positive deflection. And yeah, that basically sums up how the PQRS and T waves are visualized on ECG. Now, just to once again show what exactly is summation vector summation vector of all the electrical activity in the heart is this way. Now, why exactly am I specifying this is because you need it for the QRS axis. Now, I know that Dr. Simon mentioned about 3 ways on how to basically use, how to find out if it's left axis or right axis deviation. Here, I'm only going to discuss one method, and that is the quadrant method, because I find that to be very easy. And if I'm not really sure if he's actually asked you guys to go through all the methods, but if there's one method you guys want to know, and you need it to solve questions, approach clinical scenarios, then I would suggest that you learn the quadrant method, because it's really feasible and really easy. All right. Now, among the quadrant method, as you can see, the normal QRS axis should lie between -30 and +90. So this is +90, -30 should be somewhere around here. Okay. This is where your normal QRS axis should lie. Anything above, anything below, it's deviating. All right. So if it deviates above that, it's going to be called as left axis deviation, and this can be because of a left bundle branch block, a ventricular rhythm, a left ventricular hypertrophy, inferior MI or emphysema. This is something that you just have to memorize. You don't really want to go deep into why exactly is a left axis deviation happening because of these pathologies. Just memorize this. All right. Similarly, with right axis deviation, again, you have left bundle branch block here. You're going to have right bundle branch block here. Left ventricular hypertrophy, right ventricular hypertrophy. Sometimes it's a normal finding in children and adults. COPD with pulmonary hypertension and pulmonary embolism. Now, the thing about hypertension is sometimes in a question, they might tell you this patient was hypertensive. What axis deviation would they have? Now, when it comes to hypertension, we know this is a ventricle, right? I'm just going to try depicting a ventricle, and the ventricle pumps out blood. We're going to talk about systemic hypertension for now, okay? And we're going to see how systemic hypertension can cause left ventricular hypertrophy. So when the patient has systemic hypertension, there's obviously resistance to blood flow. Okay, when there's a resistance to blood flow, there's increase in afterload. Okay, so when there's increase in afterload, your ventricle has to work a lot more harder in order to pump blood and overcome that increased afterload, and basically push the blood out. So in order to work that hard, it's going to compensate by increasing the muscle size. And when it increases the muscle size, you're basically going to get something called as left axis deviation. So systemic hypertension can cause left ventricular hypertrophy. The same thing goes for pulmonary hypertension. So for the right ventricle, again, it's going to push the blood out into the pulmonary arteries. Now, sometimes there can be pulmonary hypertension, and when there is hypertension, there's obstruction to blood flow, and because of that increased afterload, and because of the increased afterload, the right ventricular hypertrophies, and because it hypertrophies, it can cause right axis deviation. Okay, so that's just something that you guys want to keep in mind. So sometimes they might not give you the cause of left axis deviation to be left ventricular hypertrophy. They might tell you it's systemic hypertension, but obviously systemic hypertension, if it is in a chronic state, it will lead to left ventricular hypertrophy. Same thing here. They might not give you right ventricular hypertrophy. They might just give you pulmonary hypertension or COPD. but you have to know that in a chronic condition, pulmonary hypertension and COPD can lead to right ventricular hypertrophy, okay? All right, now how would you determine the QRS axis? So as we know, the normal QRS axis is between -30 and +90, and now we need to know about our 5 more important leads, okay? We have to know that lead 1 particularly lies at 0, and AVF lies at +90. Now, lead 2 and lead 3 don't exactly lie at +90, neither does AVL lie at 0, but in order to approach questions, what I did in first year was I would generalize it. Sometimes I would not remember where exactly lead 2 and lead 3 lie, so I would just generalize it to +90. Same thing for AVL. Sometimes I wouldn't remember where exactly AVL lies, so I would generalize it to 0 degrees. This is something that will work when you're approaching a question regarding axis deviations. It will not work if they're asking you a question that directly asks you where exactly is, let's say, yeah, if the frontal plane is at 60 degrees, where exactly is it pointing towards? So you kind of want to memorize where exactly lead 2, 3, AVR, and AVL are placed. So 2 is at 60 degrees, 3 is 120, AVR -150, and then AVL -30. And the way I memorize it is that 2 is a lot more closer. So in terms of numbering, 2 is closer to 1. So after lead 1, you have 2. Okay, and then basically this was 90, so -30 would be 60, and then +30 would be 120. And then this would be 3. Okay. And then AVR would be -50. That's something that I just memorized. And then AVL was -30, because I just remembered that between this and this is where your normal axis lies. So AVL would be -30. That is something you want to memorize if they ask you a direct question. However, if you cannot memorize that and you forgot it in the exam, just in case, you will generalize it. So you will generalize lead 1 and AVL to be on 0, and you will generalize lead 2 and 3 to be on 90. Okay, but in reality, lead 2 is at 60, lead 3 is at 120 plus 120, and then lead AVL is at -30, okay? It's not really that hard to memorize, but just in case you forget it, you might want to generalize it that way, because I used to forget it quite a bit. And so that's how I would generalize and approach questions. So first things first, you want to check if AVR is negative. AVR always has to be negative, because if it is not negative, then there's probably a defect in how you placed the leads, okay? Obviously, AVR will have to be negative because your summation vector is going directly opposite from it. And in case it's positive, then that definitely indicates that there is some sort of abnormalities in the placement of the leads, okay? So yeah. Now, how would you want to determine the QRS axis? First is you want to look at lead 1 and lead AVF. Okay, let's draw. So 0 plus 90. I think this was around 180, and then this was -90. Okay, so lead 1 is positive. So like I said, what does it mean when there's a positive deflection? When there's a positive deflection, that means the vector is probably going towards the positive electrode. And because this is lead 1, this is where AVF is placed, we know for a fact that because lead 1 is positive, the vector is definitely going towards lead 1. Now, when we look at AVF, AVF is also pretty positive, right? It's going right up there. So again, we know that if there's a vector going towards a positive, then that's why there's a positive deflection or an upward deflection. And so we know for a fact that there's a vector going towards AVF. So now that we know, because lead 1 is positive, there's a vector going towards lead 1. Because AVF is positive, there's a vector going towards AVF. And when you sum up the two vectors, you're going to get your resultant vector. So this is your resultant vector, and this is your normal vector that should lie between -30 and 90, okay? Now, for left axis deviation, you want to look at lead F. Now let's draw this again. So 0, 90, 180, -90, okay? Lead 1 is positive, which means, okay, so this is lead 1, this is AVF, okay? So lead 1 is positive, which means that there's a vector going directly towards lead 1. Lead AVF, however, is not positive. Lead AVF, as you can see clearly, it's very different from the positive that was depicted here. It's more so negative. It's dipping downwards. And because it's dipping downwards, we know for a fact that there's not a vector going towards it. Instead, there's a vector going away from lead AVF, okay? Why? Because it's clearly, obviously dipping down, unlike this one where it was very obviously going up, okay? And because it's dipping down, we know that if a wave of depolarization travels away from a positive electrode, it goes in the downward, it goes in a downward direction, right? So we know that this vector is not traveling towards AVF. And now when we sum up the two vectors, this is going to be our resultant vector, okay? And this is left axis deviation caused by all of these things. You know, these causes here. For right axis deviation, you have to look at lead 1. Let's draw this again. So 0, 90, minus 90, 180. So as you can see, lead 1 is majorly downwards. Lead AVF is usually positive, okay? So because like this is really downwards. This is how your normal lead 1 should look like. And because it's mainly in the negative direction, we know for a fact that there is not a vector going towards lead 1. We know for a fact that there is no vector traveling towards lead 1. It's going away from lead 1. And in AVF, we know for a fact that there is no vector. We know for a fact that there's a vector going towards AVF because it's mainly a positive deflection. Okay, so our resultant or summation of these two vectors would be here. Okay, and so this is for right axis deviation. Is that understood? Guys, if it's not understood, please speak up because I can't like read the chats, okay? So if you have any questions up until here, please let me know and I'll really like I have no problem explaining
Yeah,
it.
I have a question.
Sure.
Can you please explain the bundle branches relating to the deviation, please?
Okay, so this is more advanced. Like this is something that you would take in third year, okay? So for now, you just want to memorize it because basically it's like this is the AV node, the bundle of his, the left and the right bundle branches. Now, if the left bundle branch gets blocked, then your interventricular septum won't depolarize this way. It's going to depolarize the opposite way. So it's like a whole different thing that you will learn in third year. For now, just memorize it. They will not ask you that much in detail, trust me.
Okay, thank you.
Of course. Okay, so did everyone understand how you determine the QRS axis? All right, moving on to intervals in ECGs. So small boxes in ECGs are equal to 0.04 seconds, and then a big box in ECG is equal to 0.2 seconds, okay? And then the amplitude, which is something that is the current, the way you would measure it is 0.5 millivolts. So this is our normal PQRST wave thingy. A PR interval starting from the P wave up until where the QRS complex starts, that has to be around 0.12 or 0.2 seconds. 0.2 seconds means that it's supposed to be, you know, about one big box or less than three small, or between like, basically, it's supposed to be 3 small boxes or 1 big box. Because if you multiply 0.04 times 3, that's going to be 0.12. So technically your PR interval should not exceed more than 1 big box, okay? If you have a prolonged PR interval, that means there is a damage to the atrial conduction pathway, or there's something that is obstructing the conduction system. So you have your AV node here, you have, sorry, not AV node, your SA node here, AV node, okay, and then you have this thing, right? Now, if you have a prolongation within the PR interval, either there is something obstructing the conduction system from the SA node to the AV node, or there's there's just something obstructing there, or there's a damage to the AV node itself, okay? So that's why it's taking so much of time for the electrical impulses from the atria to travel to the ventricles and generate a contraction, okay? A short PR interval would be seen in accessory pathways, which means that this is the SA node, this is the AV node. Now, normally it would travel like this. However, there could be accessory pathways which will reach AV node at a much shorter time than this way. So these accessory pathways will then activate the AV node, and that's why you're going to see a short PR interval, which is going to be less than 3 small boxes long, okay? Here, as you can see, the PR interval is about here. So 1, 2, 3, 4, 5, 6, 7. I think it's around 7, more or less 7, yeah. Which approximately Actually, I don't think this is 7, honestly. I think this is approximately 5. Yeah, it's about 5. So this is perfectly one big box long. So yeah, this is how your normal PR interval should be. I think I meant this as PR segment. Sorry, not AP segment. PR segment. Your PR segment has to be isoelectric. This basically denotes the time that it takes for the action potentials to be conducted through the AV node and then to the ventricles. And then the QRS complex has to be less than 3 small boxes long, which means it has to be less than 0.12 seconds. If you have a prolonged QRS interval, that means there is a bundle branch block. And by that, I mean is, let's say there's a bundle, so SA node, AV node, his, and then left and right bundle branches. If there's a damage within the his bundle or the left or the right bundle or within the Purkinje systems itself, now it's the action potential is traveling from one myocardial cell to another myocardial cell. And because it's traveling from one myocardial cell to another myocardial cell, because these guys are damaged, it's obviously going to take a lot longer. And because it's going to take a lot longer, it's going to show up as a prolonged QRS interval, like a wide QRS. Okay, it's not going to be thin. It's not going to be that thin. It's just going to be very wide, very big back. So yeah. So normally it should be less than 3 small boxes. Coming to your QT interval is at the start of your Q to the end of your T. And this has to be less than 2 big boxes. So 0.4 seconds. So basically 0.2 times 2 boxes would give you 0.4 seconds. So it has to be less than 2 big boxes. If it is longer than 2 big boxes, if it's over 0.45 seconds, that it probably indicates long QT syndrome, hypocalcemia, or drugs electrolyte abnormalities can cause a long QT syndrome. If there's a short QT, if there's a shorter QT or a shorter time between the Q and the T, then it's probably hypercalcemia, increased calcium, which can cause depolarizations at a faster rate. And so yeah. So QT interval normally should be less than 2 big boxes. If it's over 2 big boxes, either long QT syndrome, hypocalcemia, or drugs. If it's shorter than 0.32 seconds, which is about 1.5 box approximately, if it's shorter than that, then it's probably going to be hypercalcemia, electrolyte abnormalities. Now, ST segment would be this particular area right here. If there are disturbances within the ST segment, this is usually happening in cases of STEMI or NSTEMI. Now, I'm going to come to them in a bit. So yeah, here is STEMI and NSTEMI. Now, about STEMI itself says it's ST segment elevation, myocardial infarction, which means this ST segment here, it's going to be markedly elevated, okay? And NSTEMI is non-ST segment elevation myocardial infarction. So the ST segment here is usually going to be depressed or not elevated. Now, basically in STEMI and NSTEMI, in STEMI, there's a complete blockage of the artery. And because there's a complete blockage of the artery, your blood isn't able to flow. And obviously, when your blood isn't able to flow, the myocardial cells kind of just die off, okay? They get infarcted. And in this case, the infarction is transmural infarction. So this entire thickness of your myocardium gets infarcted, mainly because there's complete blockage. So complete blockage meaning no blood flow. No blood flow meaning myocardial cells keep dying. And this happens for the entire width of it because there's literally zero blood flow. Okay, so it's called as transmural ischemia or infarction. And the ST segment elevations are usually seen in leads, which are corresponding to areas of visualize. And I'm going to explain this better in a bit. But just remember that you will see ST segment elevations when there's complete blockage of your artery, and there's transmural infarction, or the entire thickness of your myocardial wall is involved. In NSTEMI, it's not infarction that's actually causing the ECG changes. That's more or less ischemia or hypoxia. As you can see in NSTEMI, the entire thickness of the artery is not blocked, so there's still some sort of blood flow. And because there's still some sort of blood flow, there are still some myocardial cells which are viable and alive, okay? So this entire thickness is not involved. It's just the endocardium that is having cells which are either hypoxic or ischemic. Now, so this is known as subendocardial ischemia, and the reason why the innermost layer of the endocardium is affected is because it's the furthest away from the coronary arteries. So obviously, because the coronary artery, now there is some blockage, but then it's not complete blockage. So there is blood flow, but the blood flow again is obstructed, so you have little blood flow, and because you have little blood flow, you're only able to supply the areas which are close to the coronary arteries, and the areas further away from the coronary arteries will not receive the blood. And that is why it's going to present as a ST segment depression or ST segment depression. Now, this is what I meant by ST segment elevations are seen in leads, which are going to correspond to the areas I visualize. Now, each of these leads were placed at different positions in our body, and therefore, because you're placed at different positions in our body, they're going to visualize a different portion of the heart. So not each of these lead is going to visualize the exact same portion of the heart. Why? Because of course you're placed at different areas of the body. Now, this is something like I want you guys to be interactive with me, okay? So, for example, if your left anterior descending artery is blocked, what are the areas supplied by that particular coronary artery? It's the anterior region or the septal region. Now, the leads visualizing the anterior and septal region are different. So for the anterior region, usually the leads visualizing those are V2, V3, V3 and V4. For the septal, so if there's a left anterior descending artery that has been infarcted and it's mainly affecting the septum, how would you know it's mainly affecting the septum? Because those stemi or elevations would be seen particularly in V1 and V2. Similarly, if your left circumflex is affected, then the area supplied by left circumflex would be the lateral portion of your heart. And because the lateral portion of your heart is affected, it's usually going to show up in your lateral leads. And the lateral leads are V5, V6, okay? If your right coronary artery is affected, then either your posterior area of the heart is infarcted or your inferior area of the heart is infarcted. Now, the leads visualizing the posterior area of the heart are going to be 2, 3, and AVF. Here, I also want to add 1 and AVL because they're also lateral. And for the inferior area of the heart being infarcted, you basically utilize specialized leads. So we've V7, V8, and V9. These are like the leads that you place at the back rather than, in the front. So the patients, you know how you place these leads in the precordium. So these leads are going to be placed at the back so they can visualize the inferior area of the heart better. But this is just extra info. It's not something they're going to quiz you on the exam. Anyway, here's the slide where I explained everything. Now, again, coming back to intervals in ECG, we covered almost everything regarding the we covered the P, the QRS, the T, the P, the PR interval, the ST segment, the QT segment, everything is covered. Now we want to know how you want to figure out the heart rate when you look at an ECG. So there's two methods. So what you want to do is you want to check the interval between each R wave, okay? And once you do that, you basically do 60 divided by the RR interval. So for example, this one here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. You know what? It's like multiple big boxes. I'm not going to calculate that. I'm weak at math. Anyway, the method that I particularly like to use is 300 divided by the number of big boxes. So here, for example, as you can see, the number of big boxes between these two R waves is 1, 2, 3, 4, 5. So if you divide that, you're going to get something around 60 beats per minute. That's your heart rate. So that's the method that I like to use. But in most cases, 60 divided by R interval is reliable, and we're going to solve a question on why exactly this method is more reliable in comparison to these ones.
Hello. I think you're muted.
Mushira? Hello?
Can you guys hear me now? Hello?
Yes, we can hear you.
Okay. All right. So I was told that you guys weren't able to hear me. So if you guys want me to repeat anything, just let me know. Or is everything clear? So if everything's clear up until this part and you guys don't have any questions, well, I have questions for you. So the patient, he's at an ECG. So he's had an ECG at a local emergency department. Attending physicians say that he has an AV nodal rhythm.
Mushira, can you reshare your screen? We can't see it.
Okay, sure. Can you see my screen now?
No.
No? Can you guys see my?
Yes, now we can see it.
All right. So this patient, he's been told that he has an AV nodal rhythm. What is the likely heart rate? Now, when it comes to basically nodal rhythms, there are different rhythms for different nodes, or you could say conduction system, right? So the SA node is the node which fires at the maximum rate, and then that's followed by the AV node. After the AV node, you're going to have the bundle of His, and then after that, basically, it's going to be all normal. So bundle of His, the firing rate of bundle of His is going to be normal to the bundle branches. It's going to be normal to the Purkinje system. Okay, now the SA node fires at the maximum rate, and that's about 60 to 100 beats per minute. The AV node fires between 40 to 60 beats per minute. And then, because all of these are equal, they're going to fire at a rate of 25 to 40 beats per minute. Now, he's been told that he has an AV nodal rhythm. What is the likely heart rate? So would it be 30 beats per minute? That would actually be too low because, once again, AV node fires between 40 to 60. Could be 50 minutes. not 65, because then that would be SA node firing, not 75, SA node firing, not 85, because that's SA node firing. So the normal rhythm of AV node is between 40 to 60. The answer is B. Now, a 60-year-old man's ECG shows that he has an RR interval of 1.5 seconds at rest. What statement best explains this condition? So we've been given an RR interval. Let's calculate the heart rate for that RR interval, and that's 60 divided by the RR interval, which is about 60 divided by 1.5. I'm going to use my calculator because I'm like genuinely that weak at math. Now that's 40. So you have 40 beats per minute. Now 40 beats per minute, that's not technically your normal rate. Usually your normal rate has to be between 60 to 100 beats per minute. Okay. Now, does the patient have fever? No, the patient cannot have fever, because in cases of fever, usually the heart is tachycardic. The patient has a normal heart rate, obviously not. So fever is ruled out, because this is definitely not a tachycardic heart rate. He doesn't have a normal heart rate to begin with. And he has decreased parasympathetic stimulation of the SA node. That is also wrong, because this heart rate is actually pretty low. And for this heart rate to be pretty low, you should have an increased parasympathetic stimulation rather than a decreased parasympathetic stimulation, okay? So no, this patient, he should have increased rather than decreased. This is wrong. He's a trained athlete at rest. This could be because usually trained athletes have a lower heart rate, and then he has a normal polarization of the SA node. Basically, this indirectly says that he has a normal heart rate, which is wrong. So the answer is D. He is a trained athlete at rest. Now, when recording AVL on an ECG, which is a positive electrode? So now, like I said, you want to memorize where exactly the positive electrodes for the leads are placed. For AVL, L for leg, so your positive electrode will be placed on your left leg. Sorry, I got confused. AVF is F for feet. So, because F for feet, that's where your positive electrode is placed on your left leg. However, AVL is for left arm. So this is going to be placed on your left arm. So remember, F for feet, L for left arm. So for AVF, this is going to be placed on left leg. For AVL, this is going to be placed on your left arm. AVR is going to be placed on your right arm. Now, if the Purkinje fibers are situated to the AV junction, becomes the pacemaker of the heart, what is the expected heart rate? Going back up here. SA node 60 to 100, AV node 40 to 60. And then the Purkinje system take over. So now they are firing. They're going to be firing between the rate of 25 to 40. So it should be A. When recording LET2 on an ECG, the right arm is the negative electrode and the positive electrode is the dash. So LET2 would be on your left leg, because 2, 3, AVF are all down. 1 and AVL are up. AVR is here, and then V2 to V6 are here. Sorry, V1 to V6 are here. So yeah. Now, a 60-year-old woman had an ECG recorded at a local ED after an automobile accident. Her weight was 70, aortic blood pressure 140. Now you want to use the information to find out the answers. Now, what is the MEA and how do you calculate it? So right now we're only given 1, 2, 3. Now, if you don't exactly remember where 2 and 3 are placed, because 1 is at 0 for sure, right? If you cannot remember where 2 and 3 are placed, generalize it to 90. Now, as you can see, most of these are downward deflections, which means that the vector for LET2 and 3 are definitely not going in their direction. They're going in the opposite direction. Okay, they're not going in their direction mainly because it's the downward deflection. They're going in the opposite direction. And so it's going to be here. For LED1, however, it's going to be a positive deflection, which means a vector is definitely going towards LED1. And so it's going to be right axis deviation. Now, is it minus 90 degrees? Because that would be no, it cannot be minus 90 degrees because minus 90 degrees is here. Right. And then this is 180. So this is not minus 90. And then is it minus 50? Could be. Is it minus 12? No, minus 12 would be a normal axis. Remember, a normal axis is between 30 and minus 30 and plus 90. Is it plus 100? No, clearly not, because if it was plus 100, it would be here. It's not right axis deviation. Is it plus 170? Again, no, it's not right axis deviation. It is B. Now, what is her likely diagnosis? Now, because this is left axis deviation, as you can see, clearly just memorize that left bundle branch block would be the answer. So yeah, the answer is B, B. Now, a ventricular depolarization wave when traveling 60 degrees in the frontal plane will cause a large positive deflection in which of the following leads? Now, this is where you want to know where exactly are these leads placed, okay? So like I said, from here, AVR is placed on minus 150, 1 is 0, and then AVF is 90. Now, I know the next thing that's closest to 1 is 2, and then after that 3, and then this is 90, so I'll subtract 3 and add 3. This way I'm going to get 60 for 2, and then plus 120 for 3, and then minus 30 for AVL. So coming back to our question here, yeah. This is traveling 60 degrees in the frontal plane. That's causing a positive deflection in which of the following lead? So it's directly traveling towards lead 2, because lead 2 is placed at 60 degrees. AVR is at minus 150. AVL is at minus 30. Lead 1 is 0, lead 2 is 60, and then AVF is 90. So the answer is D. Now, a 50-year-old man is a new employee at the ABC software. The above ECG was recorded during a routine physical exam. What is his likely diagnosis? Now, let's draw the axis. You have 1, and then 2 and 3, you can generalize it. If you don't remember. If you do, that's great for you. But I like to generalize it. So yeah. For lead 1, it's positive, which means there's definitely a vector traveling towards lead 1 because there's a positive deflection. And so there's definitely a vector traveling towards lead 1. Lead 2 is also positive. However, as you can see, lead 3 is really, really negative, right? Now, because lead 3 is really negative, there's definitely a vector that is going away from lead 3. Instead, it's going up here. Rather than going towards lead 3, it's going up here. And because of that, you're going to usually get a left axis deviation once again. And this could be the case of chronic systemic hypertension, which could lead to left ventricular hypertrophy. That's what I mentioned. So usually left axis deviation causes are left ventricular hypertrophy. Why does left ventricular hypertrophy happen? In case of chronic systemic hypertension. If it was chronic pulmonary hypertension, then that would lead to right ventricular hypertrophy. And in this case, you would see a right axis deviation, which you don't. Second degree heart block, you want a longer wither strip to determine if it's actually a heart block in the first place. Paroxysmal tachycardia, again, you need a longer rhythm strip to determine if there is tachycardia and if it's paroxysmal, which means repetitive. And tricuspid valve stenosis obviously cannot be determined because you need to hear for a murmur. So yeah, 52A. Now that basically concludes our first part of the ECG. Coming to your second part of the ECG, does anyone have any questions regarding the questions I solved? If not, then we can move on to how you want to analyze your ECG. So you always want to do it in a systematic way, right? So first things first is you want to see if there are P waves, okay? After you find that there are P waves, you want to check for heart rate and if you want to check for the rhythm. So how would you check for the heart rate? Either check Y 60 divided by the RR interval, or you can do 300 divided by number of big boxes. For regularity, you want to see if the RR intervals between each of the heartbeats are normal. And then you want to see the QRS complex. Is it broad or is it short? Usually if it's a broad QRS complex, then that would probably indicate that there's some sort of bundle branch block happening. Now you want to check for axis deviation. And then after axis deviation, you will check for the intervals. So you'll check for PR. If it's prolonged or short, you're going to check for QT segments, and you're going to check for the ST segment as well to determine if there's any STEMI or N-STEMI. Then you want to check if there's any abnormalities within the T waves or if there's an additional U wave. Usually an additional U wave is very like small. So it's like right after the T wave, there's an additional U wave, and this can happen because of electrolyte abnormalities. But this is something just extra, and Dr. Simon will definitely not quiz you on this. So yeah, T waves could be inverted or they could be upright. Inverted could be in cases of ischemia, but then again, he hasn't taught you that, so he would not bring you any abnormalities within the T waves, just something extra for you guys to know. Mainly, you want to focus on finding P waves, checking the heart rate and regularity, and checking for axis deviations and checking for the PR interval. Now, talking about tachycardia and bradycardia and sinus tachycardia and bradycardia. Sinus means that your electrical activity is originating from the AV node. Okay, and the way you can tell that your electrical activity is always originating from the AV node is because there's always a P wave followed by a QRS complex. Always a P wave followed by a QRS complex. P wave, P wave, P wave, P wave here, P wave here. There's always going to be a P wave followed by QRS complex, because basically this P wave indicates that there is SA node functional. Sorry, I meant sinus means that your electrical activity is generated from the SA node. Okay, so sinus means your electrical activity generated from SA node, and when that's happening, your atria contracts systematically, and then the impulse is sent down to ventricles, and then ventricles contract. So sinus would mean that your electrical activity is generated from the SA node followed by a QRS complex. So there's always going to be a P wave. Okay, and the morphology of most of these sinus conditions are going to be normal. Okay, so sinus tachycardia is when you have a heart rate of over 100 beats per minute, and bradycardia is when you have a heart rate of less than 60 beats per minute. So for example, in this ECG, as you can see, this is around, the heart rate would be around 300, so 150 beats per minute, 300 divided by 2, or 60 divided by 0.4, because this is two big boxes, 0.2 plus 2, 0.4, 150 beats per minute. Here, as you can see, this is about 1, 2, 3, 4, 5, 6, So sinus tachycardia and bradycardia. Sinus basically means that your electrical activity is being generated from the SA node. And because it's being generated from the SA node, you will see a very prominent P wave in almost all cases, and it's going to be followed by a QRS complex. So as you can see, prominent P wave followed by a QRS complex. Now, tachycardia and bradycardia just basically mean that either your heart rate is super fast, so over 100 beats per minute, or your heart rate is low, so less than 60 beats per minute. Okay, and basically you would calculate it either by the big box method that I use, so 300 divided by 2 big boxes, which would be 150 beats per minute, or you could just calculate using the R interval, and because this is 2 big boxes, 0.2 plus 0.2, 0.4, 60 divided by 0.4 is 150 beats per minute. Same thing goes here. 300 divided by number of big boxes is 50 beats per minute, or 60 divided by the R interval, which is about which is about 50 beats per minute. Now, regarding the rhythm is definitely going to be regular, because the R interval between each R wave is going to be equal, and there's no irregularity whatsoever. So because this is 1.2, the R interval between this would also be 1.2. Same thing here. R interval between this is 0.4. Same thing goes for this one and this one. So the rhythm is regular. It's just that either the heart rate's fast or it's slow. That's sinus tachycardia for you, and this is bradycardia. Now, coming to bradycardic conditions in general, I'm going to be covering junctional rhythm, AV blocks, because this is something that Dr. Simon went over your lecture. So regarding junctional rhythms, let's start with this ECG. First things first, like I said, you want to follow this systematic method, right? So you want to see if there are any P waves. Are there any P waves? There are P waves, okay, but they are inverted. And we're going to see why they're inverted in a few. Okay, so there are P waves, but they're inverted. Now, second thing you want to check is the R interval, so heart rate and regularity. So 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. So the R interval are equal to one another, and the heart rate would be about 300 divided by 5 would be 60 beats per minute. So that's your heart rate, and the rhythm is regular. Next, you want to check the QRS complex. Now, like I mentioned, your QRS complex has to be less than 3 small boxes. And clearly here, you can see that there is no wide QRS complex. They're all less than 3 small boxes. Okay, And then you want to check for axis deviation. So let's see. Lead 1, positive deflection, vector goes here. AVF, positive deflection, vector goes here. No axis deviation, the axis is normal, okay? Then you want to check for PR, QT, ST segment, etc. So PR here is basically going to be, so it's supposed to be around 3 small boxes or 1 big box, and clearly this is smaller than 1 big box, so these are all normal PR intervals. Your QT segment is also smaller than 2 big boxes, which is also normal, so this is your QT segment, and it's smaller than 2 big boxes, so normal finding. And then we have ST segment. There are no elevations or depressions within the ST segment. All right, now the one finding that we found was abnormal was an inverted P wave, okay? Now, where would you see an inverted P wave? In a junctional rhythm. Basically, in a junctional rhythm, your SA node is not functional, okay? Because if your SA node was functional, it would produce an upright P wave. But because it's not functional, you're having an inverted P wave, mainly because now it's the AV node generating the heart rate. When the AV node is generating the heart rate, it's going to send signals here to obviously make the ventricles contract, and it's also going to send signals upwards to make the atria contract. And because the vector is going away from the positive electrodes, you're going to see a negative deflection, which is why most of your P waves here are inverted, okay? So P waves are present, but they're inverted because the polarization wave travels from the AV node to the atria because the SA node is not functional. Rhythm is regular because the R intervals between each R wave is normal or equal. Heart rate is 60 beats per minute, and then the AV node usually fires between 40 to 60. So this is consistent with the finding. And then normal QRS complex, less than 3 small boxes, no axis deviation, and a normal PR, QT, and ST segment. Now coming to this ECG, let's find P waves. So there's a P wave here, okay? P wave here. All right, now, basically, as you can see, there's P waves, but they're very spaced out, right? And then checking the heart rate, so 1, 2, 3. 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. So approximately 5 big boxes. Our intervals are normal, equal to one another, so the rhythm is regular. Heart rate is about 60 beats per minute as well. Regarding the axis deviations, as you can see, positive deflection on lead 1, positive deflection in AVF, so this would be a normal axis deviation. Regarding the PR, QT, ST segments, now as you can see, the P wave actually starts from here, okay, and then it's supposed to end here. This is your PR interval, right? Clearly, it's way too long. It's too prolonged. So this is a prolonged PR interval. It's literally spanning 2 big boxes. So this is not a normal finding, okay? This is not a normal finding. However, regarding the T segments, the ST segment, that's normal. Your QRS complex is less than 3 small boxes, and your QT interval is about 1.5 box, which is normal. So the abnormal finding here is that the PR interval is too prolonged. All right, so this is seen in case of 1st degree AV block, where the P waves are present, not this one, sorry. These are P waves, where the P waves are present, heart rate's about 60 beats per minute, RR intervals are normal, so it's a regular rhythm. QRS complexes are also normal, less than 3 small boxes. There is no axis deviation. PR interval is pretty long though, it's over 0.3 seconds long. And but each PR interval, as you can see, so by 0.3 seconds, I meant that you start from here, right? So 1, 2, 3, 4, 5, 6, 7, 8, 9. So it's about wait, give me a second. Yeah, so it's about 0.36 seconds long, okay? 9 times 0.04 would be about 0.36 seconds. So it's about 0.36 seconds long, pretty long, right? And then this is a T wave followed by another P wave. Now it starts here. So 1, 2, 3, 4, 5, 6, 7, 8, 9. Again, it's long by 9 small boxes. So because the PR intervals are equal to one another, This is going to be a first degree AV block. So they're prolonged with similar timings. The QT ST segments are normal. Now in first degree AV block, basically what's the underlying mechanism? It's a partial blockage of the AV node, okay? So this is the AV node, and either there's increased vagal tone, so increased parasympathetic nervous system activity, or there's inferior MI, which kind of damages the AV node a bit, or there are electrolyte imbalances or drugs. Sometimes it could be a normal finding, but usually it is not something that is threatening to the patient, okay? So if it's an isolated finding, you know, if it's like a normal finding without any other symptoms, the patient is not unstable, you know, they're all normal, then you don't really have to undergo any sort of specific treatment for the patient, okay? So this is just a partial blockage of the AV node. Coming to this ECG, let's do this once again. So P waves are present, okay? P waves are present, as you can see here. Now, regarding the heart rate and the regularity. So as you can see, this is not a regular rhythm. Why? Because 1, 2, 3, okay, 1, 2, 3, and then this is like more than 3. 1, 2, 3 again, and then 1, 2, 3, 4, 5. So clearly the RR intervals are not equal to one another. And because they're not equal to one another, it's much more difficult to kind of determine the heart rate in cases where the RR intervals are not equal to one another. In that case, what you want to do is you want to check for 6 seconds on the ECG strip, okay? And 6 seconds is roughly equal to 30 big boxes. So you want to check for at least 30 big boxes, and you want to check for the contractions happening in those 30 big boxes. And you want to multiply the contractions happening within those 30 big boxes by 10, and that's how you get the heart rate in case of an irregular rhythm, okay? So this is like a very long process that I will not necessarily demonstrate for you, but you can try this out. Basically, what you want to do is check for contractions in 30 big boxes, number of contractions, multiply that by 10, and you get the heart rate. Now, in this case, your rhythm's irregular. You do have P waves. In terms of QRS complex, they're all normal, less than 3 small boxes. The ST segments are also normal. The PR segment, now coming to the PR segment, as you can see here, this is P wave, right? And then this PR segment, compare it with this one, compare it with this one, compare it with this one. Okay, and then there is no contraction happening. As you can see, they progressively increase in size. So PR interval progressively prolongs in size as you move until a beat gets dropped. So the PR interval is the longest before a beat gets dropped. And because this is a pattern that happens almost every few heartbeats. As you can see, PR interval longest before a beat gets dropped. Beat drops here, basically no ventricular contraction happening because there's no electrical impulse being conducted. So PR interval is the longest before beat dropping. So this is kind of a pattern that's repeating over, right? So this, what would you classify this as? Regularly irregular. Why would you say that it's irregular? Because the RR intervals are not normal, are not equal. But then there is a pattern that you can observe here, and that's why it's regularly irregular. Okay, and then apart from that, everything else is normal. It's just that there's a beat drop happening with prolonged PR intervals. Okay, so P waves are present, heart rate's about 90 beats per minute, and the way I calculated that is by taking 30 big boxes, multiplying contractions happening within those 30 big boxes by 10. And then a regularly irregular rhythm, mainly because the RR intervals are not equal to one another, but because there's a beat drop happening, and there's a specific pattern that you can notice here, which is basically PR being really, really prolonged before a beat drop, and then again, PR being super prolonged before a beat drop. That's like a pattern that's repeating, therefore you classify it as regularly irregular rhythm. QRS complex normal, no axis deviation, basically in the first lead and the AVF lead. You have positive deflections, which means no axis deviations, and then here you can clearly see that there is progressive prolongation of the PR interval followed by a drop beat. Now this is called a second degree AV block, but Mobitz type 1. So the characteristic of a Mobitz type 1 block is that there is progressive prolongation of PR intervals before a drop beat. And in first degree AV block, there was only prolonged PR intervals, there was no drop beat. But in case of a second degree Mobitz type 1 block, you're going to see progressive PR interval prolongation before beat dropping. And this usually happens when there is a reversible conduction block at the AV node. Mainly what happens is that the cells within the AV node, they kind of get fatigued, and therefore sometimes when they're so tired, they will not be ready to conduct the impulse to the ventricles. And that is why you'll see that after that P wave, there's going to be an isoelectric line. Why? Because the AV node has not conducted that signal to the ventricles. So there's going to be refusal of conduction of an impulse by fatigued AV nodal cells, and therefore no ventricular contractions happening. Now, in some cases, it can be because of drugs. It could be also a normal variant in cases of athletes. However, in most scenarios, it's mainly either because of inferior MI, because inferior MI causes damage to the AV node, surgeries or infections anywhere near the AV node causing damage to the AV nodal cells. If it's symptomatic, you want to treat them with atropine. Okay. Now coming to this one, visualize a P wave. Here's a P wave, here's a P wave, here's a P wave, here's a P wave. No QRS complex or drop beat. P wave again. Now you want to determine the heart rate. So 1, 2, 3, 4, 1, 2, 3. Okay, and then obviously the R interval here is pretty much quite long compared to the R intervals here. So again, the rhythm is irregular. However, because there's a pattern repeating drop beat, it's going to be a regularly irregular rhythm. Now coming to the PR intervals, QRS complex is narrow here. With PR intervals, you can see that this is just starting from here to here. Okay, 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. So as you can see, the PR intervals here are equal to one another. Okay, in Mobitz type 1, the PR intervals were getting progressively longer, and then there was a drop beat. But here, the PR intervals are equal to one another, and then there's a drop beat happening. This is known as Mobitz type 2. So you have P waves present, is an irregularly regular rhythm. The QRS complex is narrow, but usually in Mobitz type 2, there's either a conduction blockage within the bundle of His or in the Precordial system. It's usually beyond the AV node. So this is the AV node, okay, bundle of His, left and right bundle branches. Usually conduction blockage happens somewhere here. And because conduction blockage is happening somewhere there, your cardiac cells are going to pass electricity from one cell to another, and that's going to take a lot longer. And because it's going to take a lot longer, you're going to see a wide QRS complex. In this ECG, however, there wasn't a wide QRS complex, but in most cases of Mobitz type 2, you will see that there's going to be a wide QRS complex. And the PR interval is usually prolonged by an equal timing, so that's 0.28 seconds, and then it's followed by a drop beat, so non-conduction of impulse from the atria to the ventricle. The QT and the ST segments are normal. And now drop beats, however, are not preceded with a prolonged PR interval. They're preceded with a they're preceded with a long PR interval, but then this PR interval is the same as the others, okay? It's not preceded by a very long PR interval is what I meant. Now, this can progress. Type 2 is kind of dangerous because it will progress to complete third degree AV block, and that's why it might require pacemakers. In third degree AV block, basically first what we're going to do is kind of classify Mobitz 1 and Mobitz 2 and clarify the differences between them. In Mobitz 1, as you can see, P2R longer, P2R very long, and then drop beat. Okay, so PR interval progressively increases and then the beat is dropped. Here, P2R is almost equal for every contraction, and then there's a drop beat. So this is one of the main findings. Apart from that, in MOBITS 2, you will see a wider QRS complex, mainly because there is a conduction blockage happening after the AV node. And because that happens, your cardiac myocytes are going to take longer to pass the electricity down from one cell to another. So usually you see a wider QRS complex. So yeah. That's on the differences between MOBITS 1 and MOBITS 2. Coming to MOBITS 3, you have P-wave, 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 P-wave again, P-wave again, P-wave again, P-wave. You have P-waves, right? But there is literally no relation to the QRS complexes whatsoever. It's like the atria are contracting in their own time. The ventricles are contracting in their own time. So they're completely independent of each other. There is literally no association between the atria or the ventricles, okay? And this is something that's called as AV dissociation. And this is what you see in cases of a third degree AV block, atrial and ventricular dissociation. Now here, as you can see, the P waves are present, but they're completely dissociated from the QRS complex. Similarly, they're basically the atria and the ventricles are going to beat independently of one another. So the atrial heart rate is going to be different. The ventricular heart rate is going to be different. And the way you will calculate the atrial heart rate is going to be, or the ventricular heart rate is going to be basically like RR intervals between these, and you divide that. Okay, so 60 divided by the R interval. And one thing that you will notice here is that this rhythm is actually regular compared to other types of AV blocks. So second degree AV block usually had regularly irregular rhythm, okay? But in third and first degree AV block, you will notice that your rhythm is regular, okay? Because the R intervals is going to be regular, mainly because the ventricles are contracting at their own rate, okay? And so that's why you're going to have a regular rhythm. But then again, because you're contracting independently from the atria, it's called as AV dissociation. Now, both MOBITS 1 and 2 can progress to third degree. However, MOBITS 2 is at a greater rate, at a greater risk of developing to third degree AV block. And usually patients who are having third degree AV block, they have to be put on monitor. They have to be monitored on a continuous basis because this might lead to sudden cardiac death. All right, so yeah, this is how a third degree AV block looks like. And this is actually very much easier to identify compared to the MOBITS type 1, MOBITS type 2 blocks. It's just that there's complete dissociation. There's literally no relationship between the P waves or the QRS complexes. And then the rhythm's regular. Now, coming to tachycardia, Dr. Simon covered for you guys atrial fibrillation and ventricular fibrillation. So that's what we're going to be focusing on. So here, can you identify any P waves? Literally no P waves. There's like no identifiable P wave. You just have multiple QRS complexes, no identifiable P wave whatsoever, loss of isoelectric lines as well. This is in terms of atrial fibrillation. So there's no P wave present. It's an irregular rhythm because if you see this, if you see the R interval between each heartbeat, it's not the same. So this is about one big box. This is about 1.5 big box. This is about one big box again, 2 big boxes. So the rhythm is irregular rhythm because there's no appreciative pattern as well. And there's absence of isoelectric baselines. So the characteristic presentation of an atrial fibrillation is that there's no P wave and it's an irregular rhythm. This can either be because of focal activation or multiple wavelet formation. I'll be explaining that in a bit, but this is not directly fatal. However, it can lead to thrombus formation, and then this thrombus can embolize somewhere else and cause stroke. So it's not directly fatal, but you still want to put the patient on monitoring, okay? So regarding the pathophysiology behind AFib, it's either focal activation or multiple wavelets. Now, focal activation is that there could be an ectopic tissue of the cardiac muscles within the pulmonary arteries. And this ectopic tissue of cardiac muscles might just generate, not cardiac muscles, but there could be an ectopic tissue of the nodal cells within the pulmonary arteries. And, they would generate electrical impulses. And then these electrical impulses from the pulmonary arteries would come to the atria, and they would just kind of depolarize the cardiac muscles. at a much faster rate and a much haphazard rate compared to how your SA node actually depolarizes the atria. Multiple wavelets happen when there's some sort of ischemia or blockage, okay? So when there's ischemia or blockage, sometimes the normal pathway cannot be taken. So a lot of different pathways are taken, and so there's like multiple wavelets within the atria in itself, okay? And that causes depolarization over and over because of the blockage of these pathways, because of ischemia, okay? This is something that you just don't really need to know in that detail because Dr. Simon won't quiz you on this. It's just something that is for extra knowledge, basically. Now, coming to this ECG. No P waves, no appreciable pattern. Clearly, you're not able to determine if it's, basically no appreciable pattern at all. Irregular, obviously, and this is something that is a very characteristic pattern of ventricular fibrillation. So in a ventricular fibrillation, there is no pattern, no identifiable P waves, QRS complexes, T waves. The rate is about 150 to 500 beats per minute. And the ventricles, because the rate is so high, the ventricles are not able to contract, they're not able to push all the blood that they have outside the heart. And because of that, the cardiac output is severely reduced. And this definitely requires advanced life support and is fatal in most scenarios. Okay, so this is what ventricular fibrillation looks like. So basically no appreciable pattern at all. And in atrial fibrillation, you will see that you will not be able to observe any P waves at all, okay? And then in both these cases, you're going to see an irregular rhythm. And that's about it. That concludes the ECG 1 and 2 lectures. Moving on to questions. An 80-year-old man had an ECG taken at his local doctor's office. Diagnosis was AFib. Which of the condition is likely in someone with AFib? Now, like I said, in AFib, you would have no P waves, and it was an irregular rhythm. So ventricular fibrillation, which normally accompanies atrial fibrillation, in most scenarios, it could be isolated atrial fibrillation or it could be isolated ventricular fibrillation. It's not always that ventricular fibrillation will happen with AFib, no. So this is out of the equation. Strong P waves on ECG, clearly, I just said, you don't see P waves on ECG, so that's out of the equation. An irregular and fast rate of ventricular contraction. That could be true because your atria are just sending haphazardly impulses to the ventricles to contract. And this is happening at a much faster rate than it normally should. So this could be the case. A normal atrial A wave, no. A smaller atrial volume than normal, no. Usually in cases of AFib, the atrial volume is larger, and that's one of the main reasons why you're able to actually have multiple wavelets or multiple electrical impulses within the atria. So the answer is C. So AFib has rapid irregular heart rate. The atrial volume is often increased, which is causing the atrial fibrillation. Now, 61. So this is the ECG. Now, what is the diagnosis? So P waves are visualized, okay? So P waves are visualized. Now, regarding the heart rate, so 1, 2, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 6. I think this is 6 as well. Yeah. So regular rhythm, all right. And then regarding the PR interval, let's check. So 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8. 8 small boxes. So PR intervals are normal or they're equal to one another. And there is no drop beat. So no drop beat. Prolonged PR interval. Okay, and it's a regular rhythm. Heart rate's about, I think it's about like, so it's, I think 6, right? So 300 divided by 6, which would be about 50 beats per minute. Right, so it's not an AV nodal rhythm. Clearly, because if it was an AV nodal rhythm, you wouldn't have a prolonged PR. That's out of the equation. It could be a first degree AV block. Can it be a second degree AV block? No, a second degree AV block would have drop beat. A third degree AV block is not also the case because clearly there should be dissociation between the P waves and the QRS complexes. Here you can see that the QRS complex follows the P wave directly. This is not a P wave, by the way. This is something that's called as a U wave, and this happens in cases of electrolyte abnormalities. A P wave is more pronounced and you will be able to identify it better. But this small wave is definitely not a P wave, it's more of a U wave, okay? And atrial flutter, it's not atrial flutter. Atrial flutter has this classic sawtooth pattern, okay? So it's not atrial flutter. It's supposed to be first degree AV block. Yeah. Now this one, drop beat clearly has to be around second degree AV block, but again, let's just solve this. What type of second degree AV block is this? So here you can see that this is supposed to be 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. Okay, so I would assume that the PR intervals here are normal, and then there's a drop beat. So this has to be Mobitz type 2, because there's a drop beat, and then the PR intervals are equal to one another. So yeah, third degree AV block would not be this case because you would have complete dissociation, which is not something that's happening here. First degree AV block would not have a drop beat. Atrial flutter, again, sawtooth pattern that's not seen here. Atrial paroxysmal tachycardia. Now this is something that happens. Basically, it's not something you need to know, honestly. I need an ECG to explain that, which is something that I don't have right now. But yeah, you don't have to know this. Just know your blocks and you'll be good to go. So this is C, second degree AV block. Now, a 60-year-old woman comes to see her physician for her annual physical examination. She is ordered an ECG. What is the most likely diagnosis? Can you see a P wave here? There is no P wave. There's literally no P wave, no P wave, no P wave, immediately atrial fibrillation. Whenever you're not able to visualize a P wave, know for a fact that it's going to be AFib, okay? Now, question number 78 and 79. Heart rate. So, okay, so as you can tell, there's a P wave here, QRS complex, P wave here, P wave here, P wave here, QRS complex. Clearly, there is no association between atrial contraction and ventricular contraction. They are not associated because the P wave is not followed by QRS complex, okay? And so this is a case of third degree AV block. And what we know is that the rhythm in the third degree AV block is going to be regular. So it's easier for you to calculate the heart rate. How would you do it? R interval. So you will want to between the QRS complexes, right? So R interval of the QRS complexes, 1, 2, 3, 4, 5, 6. So that would be 60. Sorry, not 6. 6 times 0.2, which is 1.2, I think. And then 60 divided by 1.2 is 50, around wait. Oh. Point 1, 2, 3, 4, 5, 6. 0.2 times 6, 1.2, 60 divided by 1.2. This has to be 50. I don't think it's 37. 1, 2, 3, 4, 5, 6. Yeah, 0.2 times 6, 1.2. Yeah, no, I don't think it's 37. Your heart rate has to be 50. Yeah. And then what is the likely diagnosis here? It's a third degree AV block, complete AV block E. Yeah, I think this is wrong. This has to be about 50. And yeah, that's about it. If you guys have any questions, please don't hesitate to contact me either through my email or through my phone number. And if you guys have any feedback regarding the session, especially considering how this was my first PAL, I would really, really actually appreciate your feedback, and so that I can like improve for my future PAL sessions. And yeah, that's about it. Thank you. And just any questions, please just text me or email me.